encourage us with few words of
थोड़ी
wisdom.
बताना देखो। हाँ देख आ रही है इसको प्रोवाइड करना आ रही है ना। हाँ बस तो कोई बात नहीं कोई नहीं है। टच नहीं करना।
Very good morning to all senior faculty members and my dear students. So first of all, I would like to congratulate Department of Pharmacology and Madam Dr. Suman and Dr. Shadu and all faculty members of Pharmacology Department that they take the initiative of arranging this World Tuberculosis Day and to get young students aware about the past, present and future, what we were, what we are now and what we are projecting ourselves 10 years ahead. So as WHO has already made a statement that we are going to eradicate tuberculosis, and I think aim was in 2025 and malaria is I think 2030. So these are the two very rampant or endemic disease, and tuberculosis is the one where we have lot of challenges, especially in diagnosis. Now people are saying that we should have microbiological and radiological diagnosis before starting treatment. So it is difficult to treat. Then there are NTPC, National Tuberculosis Guidelines, which are changing now. It is now DOTS has created a lot of impact in treatment as well as in eradication of this disease. They are not only doing treatment for the case or for the patient, they are also searching for the contact who are susceptible in the family, or they are doing job in tracing those potential susceptible patients which may in future land up into tuberculosis. So tuberculosis department is also there, pharmacology, social and preventive medicine, and medicine and all. It is a cumulative effort of all. I wish all of you to make this event successful, as well as you will also get acquainted how these programs are running and how we can achieve this thing at grassroots level in a better way. Thank you very much and best of luck.
Thank you so much, sir, for a thought-provoking speech. And I would request Dr. Suman Bala, ma'am, please felicitate with a small token of appreciation. Now I would request faculty members from the Department of Pharmacology to felicitate our judges for the poster competition. I would request Dr. Suman Bala ma'am to felicitate Dr. Seema Charya. हाँ जी। Dr. Sanjay Sadhu sir to felicitate Dr. Anjali. Dr. Lalit sir to felicitate Dr. Sanjeev Kumar. Dr. Tariq sir to felicitate Dr. Megha Luthra ma'am. And Dr. Yashpal sir to facilitate Shashi Munchal. Thank you all. So without further ado, allow me to invite on stage Dr. Shalu Bawa ma'am to begin today's program with an informative talk on a snapshot of tuberculosis. Ma'am.
So, very good morning, respected faculty members, dear students. Thank you all for taking out time to be a part of this program, and I will be delighted to provide everybody with a snapshot of tuberculosis, and this will highlight the current scenario in our country as well as worldwide. Also, the challenges which we are facing, the control program, the preventive measures, and few important treatment strategies. So to begin with, I would say that probably we all are aware of the fact that tuberculosis is an age-old disease, and it is almost as old as humanity itself. It has afflicted kings and queens, poets and politicians, revolutionaries, writers, activists and actors worldwide. So from our very own country, the superstar of the millennium, that is Mr. Amitabh Bachchan, he is officially India's brand ambassador for call to action for a TB-free India. He suffered from tuberculosis in 2000, and that is why he is now the brand ambassador. And we are well aware that tuberculosis is not just a disease, it is a social and economic burden which is affecting millions of Indians. So let us all unite to end it, because every life matters, every breath counts. So some important global statistics given by WHO in its 2024 report, which says that in 2023 there were 1.25 million TB deaths, including 1,61,000 deaths amongst people with HIV. And it came up as the biggest killer, more than COVID-19 also. It is also a very important cause of antimicrobial resistance. So few other statistics, but to highlight that out of every 5 people, 2 are the ones who are infected with drug-resistant tuberculosis, which is the biggest challenge which we are facing in today's world. And also to add further, I would say that WHO has acknowledged the role of India in combating tuberculosis recently. It has acknowledged that India's success in declining TB incidence is 16% than the previous years, and the mortality has also reduced significantly. So this has definitely, this pace has doubled in declining the global TB incidence worldwide. Of course, there are a number of measures which are being taken by our country, which we will be highlighting later on. So India has definitely come a long way in curbing tuberculosis, and as per India TB report 2024, there were 25.2 lakh notified TB patients in 2023. But of course, there's a huge but over here, which says that still we carry the highest burden of tuberculosis and multi-drug resistant tuberculosis in the world. So the statistics are still making us lead over here. Being the most populous nation, we are the leaders in having the highest burden of tuberculosis and multi-drug resistant tuberculosis in the world. So just a snapshot through the evolution of tuberculosis control programs in our country. If you would say that this started in 1947, when the TB division was started under the DGHS, followed by 1951, where there was mass BCG vaccination, which started in 1951. Quickly going further, 1956 marked the establishment of Tuberculosis Research Center at Chennai. Later on, the National Tuberculosis Institute was established at Bangalore, followed by the first model district tuberculosis center in Andhra Pradesh. Then in 1962, it began with the National Tuberculosis Program. 61 to 86 started the era of conventional chemotherapy. 86 to 1993 was the era of short course chemotherapy, followed by 1993, where the DOTS intermittent regime was started. It was propagated and it was the highlight initially, but later on that became a very big reason for the spread of multi-drug resistant tuberculosis, unfortunately. So later on in 1997, the revised National Tuberculosis Control Program guidelines came into effect. And since 2019 onwards, we have the National Tuberculosis Elimination Program, which is now included in the National Strategic Plan to eliminate tuberculosis by 2025. So this is the motto given by the Ministry of Health and Family Welfare. So just a quick glance at the drug-sensitive TB program. I'm sure we all are well aware of it, but just a recap. As per the National Tuberculosis Elimination Program, which have been given by ICMR, the principle of treatment of tuberculosis, that is for drug sensitive I'm speaking, is to administer daily fixed drug combinations of first-line anti-tubercular drugs. Now the goal is and the rule is to give them in appropriate weight bands under direct observership. So the drugs, it is divided into two phases. I'm not going to go into the details. The intensive phase and the continuation phase. In the initial 2 months, the intensive phase is composed of the first-line drugs, that is isoniazid, rifampicin, pyrazinamide and ethambutol, followed by the continuation phase of 4 medications, the 3 medications, that is isoniazid, rifampicin and ethambutol. So this is how the treatment is started for a total period of 6 months in a drug-sensitive tuberculosis case, and the medications are administered according to the weight bands of every individual. So these are the guidelines for treatment of drug-sensitive TB in a pediatric case, and these are the fixed drug combinations used in National Tuberculosis Elimination Program. The red ones show the ones for the pediatric cases and the blue one is for the adult tuberculosis. So the intensive phase and the continuation phase is split out. 4 medications are given in the intensive phase and 3 medications in the continuation phase. The color coding is also done as per the National Tuberculosis Elimination Program in adult tuberculosis as well as in pediatric tuberculosis, where 3 medications are given in the intensive and followed by the 2 medicines in the continuation phase. So this was about the drug-sensitive tuberculosis. But the bigger problem and the unfortunate problem which we are dealing with nowadays, and the biggest challenge is of course the drug-resistant tuberculosis. So quickly, few definitions which have been provided to us by the WHO regarding the drug-resistant tuberculosis. The monoresistance, which says resistance to one first-line ADT medication. Polyresistance, where there is resistance to more than one first-line ADT other than isoniazid and rifampicin, which I must say are the most powerful, most effective drugs, and these drugs are given in fixed drug combinations in order to prevent the development of resistance, because they are considered as the most effective drugs and they are the ones which are administered orally. So talking about multi-drug resistance, this is resistance to at least both, now both comes over here, that is isoniazid and rifampicin. The patients are resistant to both the most important drugs, that is isoniazid as well as rifampicin, and it can be any other drugs as well. Then the iska jo bada wala part hai, that is extensively drug resistant tuberculosis, where there is resistant to the other drugs, that is fluoroquinolones, which are now the second line drugs, followed by other injectable second line drugs, that is this amikacin or kanamycin, in addition to the multi-drug resistance. So along with that, we are also carrying the baggage of the resistance to other group of drugs. So no matter how many drugs we have, we always fall short of them because of the unfortunate problem of drug resistance. So then there is another terminology, that is just rifampicin resistance. So these are our warriors: isoniazid, rifampicin, ethambutol and pyrazinamide, and if they would turn ineffective, it becomes very difficult for the patient to be treated. To combat these challenges and to overcome that, the Ministry of Health and Family Welfare has recently taken up few initiatives. The key initiative is the introduction of a new regime, that is BPALM. I will be highlighting what it stands for. This is the new drug regime started in August 2024 to boost the country's progress to achieve the national goal of ending tuberculosis in India by 2025. Besides this, there are other key initiatives which will be highlighted by Dr. Megha when she will be discussing about the National Tuberculosis Elimination Program. I'm sure they know it much better. So Pradhan Mantri TB Mukt Bharat Abhiyan, Nikshay Mitra and Nikshay Poshan Yojana. These are some of the other initiatives which are being taken place under the National Tuberculosis Elimination Program. So speaking about the new all-oral treatment for drug-resistant tuberculosis, BPALM regime, which has been recently approved by DCGI and acknowledged by Ministry of Health and Family Welfare in August 2024. It is composed of bedaquiline, pretomanid, linezolid and moxifloxacin. So now the guidelines say for every drug-resistant case, whether it is MDR or pre-XDR, BPALM regime is to be initiated. This is supposed to be more effective, less pill burden, few ADRs, effective in preventing transmission, and it is considered to be more cost effective as compared to other drug regimes. Besides this, there has been an initiative for the mandatory establishment of drug-resistant TB centers in all medical colleges, and this has come up into the Gazette notification as well. So determined to end TB by 2025, the Union Health Ministry has made it mandatory for all medical colleges to have a facility for management of MDR TB and antiretroviral therapy centers. So the way forward, and in research and innovation, we have come up a long way, definitely. There is increased access to early and accurate diagnosis using molecular WHO recommended rapid diagnostic test, increased usage of BPALM regime in MDR and rifampicin resistant cases or pre-XDR TB cases. There are a number of drugs which have come up into clinical trials in phase 1, phase 2 and phase 3. There are 30 clinical trials which are being undertaken and implementation research studies which are underway to evaluate the drug regimes or models of delivery. So now it is being emphasized to have newer models of drug delivery system. So the liposomal based or nanotechnology based regimes are being introduced for delivering ATT drugs so as to decrease the incidences of adverse drug reactions. So the progress towards reaching global UN target on TB research, it aims to license at least one new TB vaccine which is safe and effective by 2027, and currently there are 6 TB vaccines in phase 3 clinical trials as well. So the National Strategic Plan for TB Elimination as per our country says, the vision is to have a TB-free India with zero deaths, diseases and poverty. The goal is to achieve a rapid decline in burden of TB, morbidity and mortality while working towards elimination of TB in India by 2025. So still, I think we have 9 months left to achieve this target, the global target set up as well as the national target set up by our country. So to detect, treat, prevent and build. This is the National Strategic Plan for TB Elimination. First of all, we need to detect all cases, then treat them effectively, prevent the transmission of infection and build and strengthen our support system. So definitely we would be able to achieve the motto of WHO that yes, we can eliminate TB, of course. Let us commit, invest, and deliver it to our utmost priority. So this was the recent press release by the Ministry of Health and Family Welfare, which says with the motto that Jan Jan Ka Rakhe Dhyan, TB Mukt Bharat Abhiyan. Early detection, followed by the treatment, followed by the various preventive strategies, the right diet, the right preventive plans need to be followed. So I will conclude this by saying that TB harega, kabhi to desh jeetega. This is given up by the Central TB Division, Ministry of Health and Family Welfare. This is the motto in our country. So let us all abide by it. Let us all follow it. So as I said, the clock is ticking for achieving our goal, 2025. By the end of it, we need to end it. We need to eliminate it from our country. So thank you all once again and congratulations for the World Tuberculosis Day commemoration.
Thank you so much, ma'am, for the insightful and informative presentation. I think your snapshot of TB is the complete overview of TB, which deepened our understanding of the disease in a better way. Next, we have an interactive session. It is a role play by our MBBS students. It was their brainchild, their idea, they prepared all things by the students only, and it is related to the TB dilemmas, counseling issue, adherence issue in the treatment of tuberculosis. So without further ado, let's welcome our students for this role play.
Ladies and gentlemen, doctors and drama lovers, welcome to today's skit where we take on one of the oldest, yet still stubborn villains of the medical world, TB.
Tuberculosis, or as we commonly call it TB, is a disease that has been crushing human population for years now without an invitation. It spreads silently, hides inside your lung, and if you don't treat it properly, it comes back stronger like that one WhatsApp text from your relatives.
But fear not, science has armed us with powerful medications, our pharmacological superheroes. To defeat this villain, however, in any superhero movie, if hero doesn't complete his mission, then villain returns stronger.
So today we present to you a mix of medicine, laughter and a touch of Bollywood-style drama as we unfold the story of a man, his sassy wife, a confused doctor and a mighty TB drop. So buckle up because it's not just any skit, it's a TB fighting adventure.
नमस्कार बैठिए डॉक्टर साहब क्या बताऊं मैं आपको मेरे को लग रहा है मेरे को कुछ सीरियस हो रहा है अच्छा से ये खांसी जो महीनों से जाने का नाम ही डॉक्टर साहब
जी और मेरा तो कान का पर्दा ही फट गया है पहले ही मैं इनकी खिचखिच से परेशान रहती
क्या दिक्कत आ रही है वैसे आपको ऐसा तो नहीं कि आपको बुखार सा हो रहा हो
अरे हाँ डॉक्टर साहब बुखार तो रह रहा है आजकल
लगभग कितना होता है कभी नापा है आपने और ऐसा कभी शाम को बढ़ रहा हो ऐसा लग रहा है आपको
ओ डॉक्टर साहब शाम को तो आजकल बढ़ रही है डॉक्टर साहब बुखार तो
अच्छा बढ़ रहा है और ये बताइए जो आपकी खांसी है ये बलगम वाली होती है सूखी होती है
हाँ डॉक्टर साहब बलगम हो रही है
बलगम हो रही है
हाँ
उसमें खून जैसा कुछ आ रहा है
हाँ डॉक्टर साहब हाँ बलगम में खून के धब्बे भी दिख रही है आजकल तो
अच्छा दिख रहे हैं और ऐसे से लग रहा हो वेट लॉस सा लग रहा हो कपड़े ढीले ढाले से हो गए
हाँ डॉक्टर साहब पहले मैं 100 किलो का हुआ करता था अब घट करके मात्र 80 किलो का रह गया हूँ मेरे को लग रहा है डॉक्टर साहब मेरा जिम काम कर रहा है
अच्छा
और इनका ट्रेनर इनको अभी भी पोटैटो पप्पू ही बुलाता है
चलिए मैं एक काम करता हूँ एक बार आपको देखते हैं जब मैं बोलूँ खांसने के लिए तो खांसेगा अपने मुंह के आगे हाथ रखिएगा ठीक है
डॉक्टर साहब
खांसिए 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 एक और बार अच्छा मैं समझ गया यानी क्या है, एक काम करता हूँ, मैं आपको एक टेस्ट लिख के देता हूँ, एक स्पुटम टेस्ट है, वो कराइए, उसके बाद आके देखते हैं, ठीक है?
डॉक्टर साहब,
चलिए,
धन्यवाद।
नमस्कार।
अब इस पे अपने बलगम का सैंपल दे देना, लंबी सांस लो और जब खांसी है तब दे देना। और एक एक कंटेनर दे जाइए, इसमें कल आप सुबह बिना ब्रश करे, बिना कुल्ला करे सैंपल लेके आ जाओ। आहा, माइकोबैक्टीरियम ट्यूबरकुलोसिस। You have TB.
क्या ट्यूबरकुलोसिस? अरे डॉक्टर साहब, ये सब मेरे को कैसे हो सकता है?
हाय टीबी, अब ये क्या बला है? अब मेरे टिंकू पिंकू का क्या होगा?
अरे डॉक्टर साहब, मेरा भाई ठीक तो हो जाएगा ना, बेचारा सूखता जा रहा है दिन ब दिन।
हाँ जी, हो जाएगा, टेंशन मत लीजिए।
तुम्हें तो सिर्फ अपने भाई की पड़ी है, हमारे चिंकी मिंकी का क्या? डॉक्टर साहब, आप ये बताइए, कहीं ये बीमारी छूने से तो नहीं फैलती है?
नहीं नहीं, चिंता मत कीजिए, छूने से नहीं फैलती है, ये फैलती है हवा से। और जहाँ तक उसकी बात है, आप अपना मुंह कवर करके रखिए, मास्क लगा के रखिए, जैसे गमछा लगा रखा है, इसे लगा के रखिए और पेट भर के खाना खाइए। और जहाँ तक बच्चों की बात है, उनकी इम्यूनिटी कम होती है, छोटे होते हैं, तो इस चक्कर में उनके अंदर फैलने का खतरा ज़्यादा होता है, तो उनसे थोड़ा प्रिकॉशन बना के रखिए, ठीक है ना? चलिए।
अरे डॉक्टर साहब, आप इसे बस ठीक कर दीजिए, मेरा एक ही छोटा भाई है।
अरे अरे, वैसा आप टेंशन मत लीजिए, टीबी का ट्रीटमेंट है, आपको क्या करना है, 6 महीने का मेडिकेशन कोर्स है, वो करना है। और खासकर पप्पू जी, अपना ध्यान रखिएगा, वो जो मेडिकेशन का कोर्स है वो छोड़िएगा मत, ठीक है ना? नहीं तो साइड इफेक्ट्स वगैरह होते हैं, जब भी बाहर जाएं मास्क लगाएं, गमछा पहने, थोड़ा बच्चों से दूरी बना के रखें, उनके अंदर ज़्यादा तो होता है, ठीक है ना?
हाँ हाँ, पर ये ड्रामा किंग पप्पू कोर्स कंप्लीट करेगा अभी?
अरे ये तो पूरा कोर्स कंप्लीट करेगा, लेकिन डॉक्टर साहब आप ये तो बताइए, ट्रीटमेंट है क्या?
ट्रीटमेंट ये है।
Now let's introduce you all to the various anti-tubercular drugs. First, rifampicin, the colorful crusader, turning the tide and sometimes your body fluids. Then isoniazid, the wall demolisher, always ready to break down bacterial defenses.
Joining them, pyrazinamide, heatwave hero, cranking up the temperature to make those bacteria spread. Then there is ethambutol, the eagle eye, keeping sharp lookout but can cause visual dullness. And last but not the least, streptomycin, the silent shooter, delivering a potent punch.
rifampicin in the house. टीबी का इलाज है मैम पास, टीबी नहीं करेगा लास्ट। माय लाइफ में सिर्फ एक चेंज, योर पी विल बी ऑरेंज।
ऑरेंज पी? अरे नहीं नहीं डॉक्टर साहब, मेरे को तो 6 पैक्स ऐप चाहिए थे, बाथरूम में रेनबो नहीं।
अब ये बाथरूम में रेनबो भी बनाएंगे, पहले 1 घंटा लगाते हैं।
उल्टी, मैं हूँ आइसोनियाज़ाइड, द मोस्ट पावरफुल। मैं करती हूँ टीबी पे सीधा बात, अगर नहीं लोगे विटामिन B6 तो तुम्हारी नसों में झंझनाहट भी कर सकती है।
डॉक्टर साहब, ये क्या ट्रीटमेंट हो रहा है या टॉर्चर कर रहे हो आप?
स्टूडेंट्स, आप बताइए।
आइसोनियाज़िड आपकी नर्व्स को डैमेज कर सकता है, इसीलिए हम आपको इसके साथ विटामिन B6 देते हैं।
मतलब घर के कामों से ऑफिशियली छुटकारा, अब बर्तन भी मुझे ही करने होंगे।
मैं हूँ पैराजिनामाइड, मैं सिर्फ एसिडिक पेट में काम करता हूँ, इसलिए मुझे नॉर्मल पेट में कम मत करना। हाँ, लेकिन मैं तुम्हें एक छोटा सा परेशानी दे सकता हूँ, तुम्हारे जोड़ों में दर्द होगा, नुकसान थोड़ा है पर आराम पूरा मिलेगा।
एसिडिक कंडीशन? अरे डॉक्टर साहब, अब क्या मुझको इसको नींबू पानी के साथ लेना पड़ेगा?
नहीं पप्पू जी, इसका मतलब है ये दवा एसिडिक एनवायरनमेंट में ज़्यादा अच्छे से काम करती है।
ओह।
हेलो, क्या मैं आपकी कुछ मदद कर सकती हूँ? लेकिन इसके लिए आपको अपनी आंखों का ध्यान रखना होगा, क्योंकि इससे आपको कलर ब्लाइंडनेस हो सकती है। बीमारी का इलाज होगा, लेकिन प्यार से।
ये क्या डॉक्टर साहब, अगर पप्पू कलर ब्लाइंड हो गए तो मेरी सुंदरता कैसे देखेंगे? हाँ हाँ कुट्टी, आई तो बड़ी हूर की परी।
अरे तुम ये ड्रामे अपने घर जाके कर लेना।
बेटा, मैं हूँ स्ट्रेप्टोमाइसिन, इंजेक्शन इन सबसे ताकतवर, पहले ही दे रहा हूँ इंफॉर्मेशन, बहरे होने का रहेगा डर।
ओ भाई, चिल्ला क्यों रहे हो? धीरे भी बोल सकते हो।
इसलिए क्योंकि स्ट्रेप्टोमाइसिन से हो सकता है हियरिंग लॉस, तो हम इसे बहुत स्पेशल कंडीशंस में देते हैं।
इसका मतलब घर के सभी लोग पप्पू को डांट सकेंगे? आप एक काम कीजिए डॉक्टर साहब, ये जो
स्ट्रेप्टोमाइसिन होता है,
स्ट्रिप्टोसिन जो भी है ये थोड़ा एक्स्ट्रा लिख दीजिए।
ठीक है।
अरे डॉक्टर साहब यार, एक बात बताओ, ये तो टीबी से ज्यादा मुझे डरा रहे हैं। मेरे को नहीं कराना कोई इलाज और कोई साइड इफेक्ट्स हो पहले ही बता दो।
हम करेंगे तुम्हारे लिवर पे बार,
हेपेटोटॉक्सिक ड्रग्स।
क्या?
हाँ, these drugs cause hepatotoxicity, इसलिए हमें आपको ड्रग मॉनिटरिंग के अंदर रख।
हे माँ, माता जी, ड्रग देके मॉनिटर करना होगा। ये क्या कह रहे हैं डॉक्टर साहब?
नहीं नहीं, इनका मतलब है कि ड्रग मॉनिटरिंग, उसमें क्या होता है, जब हमको ड्रग देते हैं तो उसके देखना होता है कि साइड इफेक्ट्स तो नहीं आ रहे या फिर सही से काम कर रही है नहीं कर रही, तो इस वजह से उसे मॉनिटर करना पड़ता है। इसे हम कहते हैं ड्रग मॉनिटरिंग। हम उस पर रखेंगे।
पप्पू जी, आप चिंता मत कीजिए, 6 महीने का कोर्स है, उसके बाद आपकी लाइफ नॉर्मल हो जाएगी।
क्या नॉर्मल? डॉक्टर साहब, ऑरेंज पी, जोड़ों में दर्द, विजन प्रॉब्लम, नर्व टिंगलिंग, हियरिंग लॉस। अरे डॉक्टर साहब, इलाज कर रहे हो या मुझे और बीमारियां ही दे रहे हो?
कोई नहीं बाबू, वो इसके साइड इफेक्ट्स है, मैंने आपको बोला था। पर आप क्या काम करिएगा, इसे छोड़िएगा नहीं तो दिक्कत हो सकती है।
ठीक है डॉक्टर साहब।
The side effects of TB are manageable. The benefits of curing TB far outweigh them.
अच्छा डॉक्टर साहब, एक बात बताओ, अगर मैं 6 महीने से पहले अगर दवाई छोड़ दूं तो
फिर
तो उससे होगा MDR TB.
क्या मुझे दोबारा से टीबी? अरे नहीं डॉक्टर साहब।
अरे नहीं नहीं बाबू जी, इसका मतलब होता है मल्टी ड्रग रेजिस्टेंस टीबी। अगर आप दवाई पर छोड़ दोगे 6 महीने से पहले तो टीबी वापस से आएगा, और इतनी खतरनाक तरीके से आएगा कि जो नॉर्मल मेडिकेशन है उससे भी कंट्रोल नहीं हो पाएगा।
मतलब विलन वर्जन 2.0, कमजोर टीबी का स्ट्रॉन्ग भाई।
कह सकते हैं थोड़ा बहुत, पर आपको मेडिकेशन पूरी रखनी होगी।
अरे डॉक्टर साहब, ऐसा कुछ नहीं होगा, इसकी मेडिकेशन मैं पूरी कराऊंगा।
और इंडिया में हम अंडर गवर्नमेंट प्रोग्राम फ्री ट्रीटमेंट देते हैं, सो नो एक्सक्यूजेस।
और आपको अल्कोहल और स्मोकिंग सब छोड़ना होगा। आपको सिर्फ घर का खाना खाना होगा।
नो अल्कोहल, नो स्मोकिंग। अरे डॉक्टर साहब, मैं अपने ठीक होने की पार्टी कैसे दूंगा?
हमें तो कभी पार्टी दी ही नहीं।
डोंट वरी पप्पू, तुम 1 महीने का ट्रीटमेंट पूरा करो, हम तुम्हें ग्रैंड पार्टी देगा।
अच्छा ठीक है डॉक्टर साहब, मैं वादा करता हूँ कि मैं अपनी ट्रीटमेंट टाइम से लूंगा। पर एक लास्ट क्वेश्चन पूछ सकता हूँ क्या?
जी पप्पू जी।
डॉक्टर साहब, वो मेरे को समोसे खाने मिल सकते हैं क्या?
इस पागल पप्पू को अभी भी समोसे खाने की पड़ी है।
अब मैं इनका क्या करूं? आप ही समझाइए डॉक्टर साहब।
पप्पू जी, आप खा सकते हो कुछ भी, पर घर का बना हुआ खाइए, ठीक है?
ये लो, अब एक और काम। पप्पू, क्या तुम तैयार हो सुपर हीरो बनके टीबी विलन से लड़ने के लिए?
यस।
और इसका ट्रीटमेंट तो मैं पूरा कराऊंगा, चाहे पीट पीट कर पूरा कराना पड़ो।
कोई नहीं, मारिए मत इन्हें। पप्पू जी, मैं आपको एक आपका टीबी ट्रीटमेंट मंत्र बताता हूँ। टेक मेडिसिन डेली, डोंट बी लेजी, अदरवाइज टीबी विल गिव क्रेजी।
ठीक है डॉक्टर साहब।
6 महीने दवाई ढंग से लें, टीबी से छुटकारा पाने की गारंटी हमसे। Ladies and gentlemen, as we finish the tale of misadventure of TB, let's recap with a sprinkle of humor and a heap of wisdom. So, if you feel unwell or something amiss, consult your doctor, don't dismiss.
Remember, stay strong, stay healthy, and until next time, keep smiling, keep learning, and spread the cheer. Thank you.
रंजन को जगाना है, टीवी को भगाना है। थैंक यू।
What a fantastic performance. Thank you so much. Now, for the next session, we have with us our next speaker, Dr. Shavani from the respiratory medicine. She will be talking on the tuberculosis then and now. Ma'am, please.
A very good morning to all of you. So, first of all, the role play that was done by the MBBS students, it was very nice. There was no exaggeration in the questions that the patient was asking. Even they hit your head in the OP about the questions. And maintaining the compliance is the main important thing that a physician has to do. I am Dr. Shravani, Assistant Professor from Respiratory Medicine. Today I will be talking about tuberculosis then and now. It will be a brief presentation about the history of TB and the clinical aspects of tuberculosis presentation and diagnosis. So World TB Day, as we have already discussed this, on March 24, 1882, Dr. Robert Koch announced the discovery of Mycobacterium tuberculosis, the germ that causes tuberculosis. A century later, in 1982, the global health community recognized it as World TB Day. So, a brief history of tuberculosis. Tuberculosis has been a permanent and persistent challenge to the humankind. It is hypothesized that the Mycobacterium genus originated more than 150 million years ago. Earliest evidence of tuberculosis was seen in Egyptian mummies, which showed skeletal deformities characteristic of pot spine, which is spinal teeth. Ancient Indian scriptures have been the earliest written evidence of tuberculosis 3,300 years ago. There are very different interesting names given to tuberculosis throughout history based on different presentations and observations, like phthisis, which is a Greek word which means abscess, consumption, which is a European terminology for tuberculosis because the patient is consumed by the disease, the patient gets wasted away. It is also known as white plague because it spread like the plague and the patient was pale. And it is also called as robber of the youth because it was a common cause of death among youngsters. These are some cartoons of that era, of the 18th century, when the tuberculosis was almost equated to death. As you can see, there is a small boy who is suffering with tuberculosis, and there is a claw of death looming over him. And this is a patient of tuberculosis on the bed, and this is tuberculosis as death looming over his body. Science took its first real step towards the control of tuberculosis in 1868, when a Frenchman, Jean-Antoine Villemin, proved that TB was in fact contagious. Because before that, people believed that it was hereditary. In 1882, Robert Koch successfully isolated the germ. So this is a picture of Robert Koch presenting addressing the Physiological Society of Berlin, presenting his findings of isolating the germ that caused tuberculosis. And this is a paper that he published 2 weeks later in a German journal. He was awarded the Nobel Prize in the field of medicine for his scientific achievements in 1905. So the work of Villemin and Koch did not immediately lead to a cure, but their discoveries helped revolutionize the popular view of the disease. Now people understood that it was spread through cough and sneezes, and you had to stay away from the people of tuberculosis. So Dr. Edward Livingston Trodu was the first American to promote isolation as a means not only to spare the healthy, but also to heal the sick. Trodu believed that a period of rest and moderate exercise in the cool, fresh air of the mountains was a cure for tuberculosis. Hence came the concept of sanatoriums. So sanatoriums and open-air schools were institutes that were formed for caregiving of the tuberculosis patients and also to prevent transmission to the non-infected people. So after Robert Koch announced the discovery of tubercle bacilli, there was a path of innovation. In 1943, the first drug streptomycin was discovered against tuberculosis. Then came PAS, which is para-aminosilicic acid, then isoniazid, pyrazinamide, cycloserine, ethionamide, kanamycin, and all the other drugs that you have been learning about. And the latest drug to add into this is pretomanid in 2019. So along with the drugs that have evolved, there has been a development in the concepts of tubercular therapy. So in 1946, there was a first controlled clinical trial comparing streptomycin versus bed rest in patients of tuberculosis, which reduced the death rate, but resistance emerged in 85% of patients. In 1948, a combination of streptomycin and PAS reduced the emergence of resistance. So this led to the concept that multi-drug treatment prevents acquisition of resistance. In 1952 to 56, isoniazid was added to this regimen, which led to decreased emergence of resistance, result to 90 to 95% cure rate. In 70 to 74, other rifampicin and pyrazinamide were included in the treatment, which shortened the treatment duration from 24 months to 6 months. Hence came the concept of sterilizing drugs that help eradicating persistent bacterial populations and eliminate the treatment shortening. 1976, the 4-drug regimen that we are using right now was introduced: isoniazid, rifampicin, pyrazinamide, and ethambutol. And then in 2012, bedaquiline was approved. In 2014, delaminate was approved.
And 2019, as we have already learned about the NICS TB trial, which included bedaquiline, pretomanid and linezolid regimens. And we are also on the way of substituting rifampicin and ethambutol with rifapentin and moxifloxacin to shorten the duration to 4 months. But this has not been introduced in India till now. So brief overview about the clinical presentation of tuberculosis. So as you all know, tuberculosis is a disease that can be caused in all the organs of the body from head to toe. It only spares the hair and nails. All other organs can be infected by tuberculosis. So the main symptoms of pulmonary tuberculosis are appetite loss, fatigue, chest pain, coughing up of blood, productive and prolonged cough, night sweats and pallor. And in extrapulmonary tuberculosis, the main sites involved are CNS causing TBM, which is tubercular meningitis, lymphatics or scrofula of the neck, cervical lymphadenopathy, tubercular pleurisy, disseminated tuberculosis, miliary tuberculosis, bones and joints of spine, Pott's disease or spinal tuberculosis, genitourinary tuberculosis. Diagnostic tests that are used in tuberculosis. So the main important TB diagnostic methods can be classified as 3 groups. First one is immunological tests. So immunological tests are the tests that assess the cell-mediated immunity that has developed in a person after exposure to the tubercular antigen. So first is tubercular skin test. In this case, a tubercular antigen is intradermally injected into the volar aspect of a forearm. Then you have to assess the induration size after 48 to 72 hours to assess the immunity reaction of the patient. Other antigen antibody mediated tests include ELISA and IHC based tests. Adenosine deaminase, this is an important test used in extrapulmonary tuberculosis because this is an enzyme that is released by CD4 T cells. So the amount or levels of ADA in the pleural fluid, CSF or ascitic fluid can be helpful in diagnosis. Interferon gamma release assay is also another immunological test which is also called as T-spot TB test, in which we measure the cytokine interferon gamma that is released after exposure to the tubercular antigen in the blood. This is the other name for this is quantiferon TB gold. But the gold standard for diagnosis of tuberculosis is always microbiological studies. So sputum microscopy, as you must have already learned in microbiology about the acid-fast bacilli, Zeal-Nielsen staining, auramine-rhodamine staining, and solid and liquid cultures for isolating the bacilli from the specimens that you submit. So with the emergence of drug-resistant TB, there are other DNA-based assays that have become important. So GeneXpert MTB-RIF, this is a cartridge-based nucleic acid amplification test that identifies the MTB gene and RPOB gene for rifampicin resistance. And another one is line probe assay, which is a PCR-based technique which amplifies the DNA and identifies resistance to isoniazid, rifampicin, fluoroquinolones, and second-line injectables. Some advanced techniques which are used based on mass spectroscopy or mass spectrometry, are GCMS and multi-TOF, which have early and accurate diagnosis of tuberculosis along with resistance to a wide range of drugs. Clinical course of tuberculosis. So this is an important concept that all clinicians should be aware of. So on first, when the patient is exposed with the Mycobacterium tuberculosis bacilli, the patient eliminates the infection. If the patient eliminates the infection by innate immune response, the bacilli is not present in the body. So the tubercular sensitivity test is going to be negative because no memory T cell is present because there is no cell-mediated immunity that has happened. If the infection is eliminated but with acquired immune response, that means a secondary immunity or cell-mediated immunity has developed, he will have a strong CD4 response to the antigen, hence the TST and IGRA are going to be positive. But because the infection is eliminated, there is no culture or sputum smear positivity, infectious, patient is not infectious, there are no symptoms and there is no need of treatment. So latent TB infection. This is the case when a patient is not able to eliminate the infection completely from the body. So Mycobacterium tuberculosis is controlled by the cell-mediated immunity, but it is not eliminated. The patient is harboring the bacilli in a dormant or latent form. So TST and IGRA are going to be positive in this case also, but culture and sputum smear positivity is negative because the patient does not have any disease. He has only developed a latent TB infection. In this case, it is preferred that the patient is given preventive therapy so that the patient does not develop into an active disease. Then comes subclinical TB disease where the symptoms are only mild, and then active TB disease where the symptoms are mild to severe. In both these cases, the patient needs a multi-drug therapy. This is the natural course of a patient who is infected by the MTB bacilli, and based on the stage that the patient is present, there will be different tests that come positive and different treatments that are preferred. So one of the biggest challenges in tuberculosis is to understand why exactly some individuals successfully clear the bacilli or maintain it as latent TB, while others progress to active and more severe forms of the disease and even die. So the most important factor in this is host factors, that is immunosuppression, nutritional level or nutritional support to the patient, socioeconomic conditions. These can affect the patient's immunity in a very big way. Treatment of tuberculosis, the pharmacotherapy part of treatment of tuberculosis was very well described by Dr. Sharma, so I won't be repeating it again. But as a clinician, I would like to add to that apart from pharmacotherapy, it is very important that the patient gets nutritional and socioeconomic upliftment. As we all know, tuberculosis is a disease of poverty, malnourishment and overcrowding. So important part of treatment includes socioeconomic, nutritional and psychological support apart from pharmacotherapy. And as clinician, we should be able to encourage the patient to maintain the compliance of treatment and also to make them aware about the safe behavior to reduce transmission of infection. Also in conclusion, I would like to add that in the last 5 years, our institute has treated 3,064 pulmonary TB patients, 2,328 extrapulmonary TB patients and 93 drug-resistant TB patients. So as the theme of this day suggests, yes, we can end TB, but we have a long way to go. I hope we are on the right path. Thank you.
Thank you, Dr. Shavni, for enlightening us about the clinical picture of tuberculosis. Thank you for sharing such a beautiful talk with us. Now, I would like to invite a student of MBBS batch 2023, Jayapratap Singh, for reciting a touching poem on the suffering of a TB patient. So let us hear from him. Okay.
Good morning, respected faculty members and my dear batchmates. Today I, Jayapratap Singh Sidhu, would be reciting a poem on tuberculosis. कि लिखा है, धुंधली आंखें और सांसें बारी शारीरिक लाचारी, धुंधली आंखें सांसें बारी और शारीरिक लाचारी, छूट गया हंसी का प्याला, छूट गया टीबी ने हर सुख को है डाला, धीरे धीरे कम होता जा रहा दम, धीरे धीरे कम होता जा रहा दम, टीबी ने हर सुख को डाला, अंदर जलता टीबी का गम, खांसने को रोकने की, खांसी को रोकने की जगते सुपने कर रहे हैं पुकार, टीबी है एक अनसुनी कहानी, टीबी है एक अनसुनी कहानी, इसको सुनने की कर रहे हैं हम गुहार। जागरूकता है मरीजों की सुरक्षा के लिए जरूरी, जागरूकता है मरीजों की सुरक्षा के लिए जरूरी, इलाज की तरफ बढ़ता वक्त का पाबंद हर कदम दूर करेगा हर मजबूरी। रातों में बहता पसीना, रातों में बहता पसीना, थकान भरी ये चाल हुई, हौसले हैं बुलंद, हौसले हैं बुलंद, सावधानी को बनाना होगा ढाल इसकी, दवा समय पर अगर लोगे तुम, दवा समय पर अगर लोगे तुम, जग में फिर से खेलोगे तुम, जग में फिर से खेलोगे तुम। खांसो तो मुंह को ढक लेना, खांसो तो मुंह को ढक लेना, साफ हवा में रह लेना, कपड़े चादर धुलवा लेना, दवा समय पर ले लेना, छोड़ना नहीं, छोड़ना नहीं मगर आदत बना लेना। पौष्टिक भोजन और आराम सही, पौष्टिक भोजन और आराम सही, तभी बनेगी सेहत नई। टीका लगवाओ, जांच करवाओ, अब टीबी नहीं है ला इलाज, रखना होगा दवा पर पूरा विश्वास। मत छुपाओ मत सहो तुम, मत छुपाओ मत सहो तुम, इलाज का दीप जलाओ, टीबी को हमने है हराना, टीबी को हमने है हराना, आओ मिलकर सबको है बताना, आओ मिलकर सबको है बताना। थैंक यू।
To please deliver a talk on national eradication of TB. So let us peep through window of Dr. Megha what all is happening around to eliminate tuberculosis.
Thank you, Dr. Lakshmi. Thank you very much, Department of Pharmacology, for organizing such an enlightening event. Without further ado, I will proceed with a few words about National Tuberculosis Elimination Program. As already we have come to know, this year's theme is Yes, we can end TB. We have to commit, invest, deliver. This is a bold call for hope, urgency, and accountability from the World Health Organization. In a brief overview of the program, I would like to tell you all that it is an initiative. The National Tuberculosis Elimination Program is an initiative by the Government of India aimed at eliminating tuberculosis in the country by 2025. This is 5 years ahead of the global target. The World Health Organization and the various signatories to this organization have pledged to end tuberculosis from the world by 2030. This program was earlier known as Revised National Tuberculosis Control Program, abbreviated as RNTCP. And in 2020, it was renamed as National Tuberculosis Elimination Program to emphasize its goal. So, had it been a class, I would have started asking what is the difference between elimination and control. But right now, I'm pretty sure you have prepared the posters so well, you have read about the topic so well. So I'm pretty sure that you already know the difference between control and tuberculosis. Like Dr. Shalu already pointed out, it is guided, this program is guided by the National Strategic Plan from 2017 to 2025 and focuses on the 4 pillars: detect, treat, prevent, and build. So obviously this means we need to detect cases, about 85% of them, treat 90% of the detected cases, prevent transmission to others, because if there is one TB positive case in a family, the rest of the family is automatically predisposed. And finally, build up or consolidate our achievements. The objectives of this program include early diagnosis. About 85% of the cases should be diagnosed. Prompt treatment with quality assured drugs. So the treatment has to start immediately and we have to maintain the quality given the fact that the treatment is totally free of cost in this program. So free treatment should not equate with lower quality treatment. We have to engage with patients in the private sector. So it has been noted pretty frequently that when tuberculosis patients go to private practitioners, they treat according to their own regimen. Whereas the National Tuberculosis Elimination Program regimen, it is highly researched, it is highly effective, and it is tailored to suit the need of the masses. So we need to rope in our private practitioners. We have to, converge with them and also ensure that they prescribe standard regimens which have been tailored to the needs of the masses. We have to implement prevention strategies such as contact tracing and airborne infection control. You must have noticed that I was constantly looking at the mode of transmissions in your posters because we frequently ignore either one of the two modes of transmission. One is the droplet infection. Droplet infection is when the droplets, they are released when we are talking in a loud volume, shouting, laughing, coughing, sneezing, or singing. So in these activities, droplets of the sputum, they are formed and released. The droplets, they can travel for about 1 meter. So that 1 meter area has to be protected. It can either be done by the use of a mask or it can also be done by maintaining a distance. But when these droplets, they dry up, the smaller droplet nuclei, they can be transported by currents of air. And droplets also settle down on bed linen and table surfaces, chair surfaces, etc. So we need to clean up the surfaces and but later on, when the droplets dry up, the droplet nuclei, they start transmitting through the air. So maintaining proper ventilation and also keeping the air clean is very important to prevent the spread of TB. That is why tuberculosis is also a disease of poor, overcrowded conditions. India already has made significant progress under National Tuberculosis Elimination Program with a decline in TB incidence by 16% and deaths by 18% from 2015 to 2022. However, India still accounts for 27% of the global TB burden. Approximately 2% of tuberculosis patients in India are co-infected with HIV. Hence, there is a lot of emphasis we are giving for the early diagnosis and prompt treatment of TB in HIV, which also happens to be either multi-drug resistant or extensively drug resistant. Around 2.5% of new TB cases and 13% of previously treated cases are drug resistant. So by now you must have read during your extensive preparation for the posters that the treatment of drug-resistant TB is more expensive, more difficult. The patient has to undergo a lot of adverse effects also. It is also longer. So there has been an alarming rise in multi-drug resistant TB, especially among children and adolescents. This form of TB is resistant to the two most effective first-line treatments, rifampicin and isoniazid. But we have made considerable progress. Our achievements are an in-country model for TB burden estimation. If you go through the flowcharts, which are mentioned in the diagnostics section of the National Tuberculosis Elimination Program, these flowcharts, they clearly guide the practitioners and the physicians for diagnosis, quick and easy diagnosis of tuberculosis. So this is something which has been developed indigenously and in-country model, and this has been appreciated world over. Second is public-private mix model. It was observed that a majority of patients, they first report to a private practitioner, and the private practitioner will not initiate any standard treatment protocol. They will follow one of their own clinical protocols, and that was actually contributing to drug resistance. So we have come up with the solution of a public-private mix model. Community engagement and awareness. As you know, this is a multi-drug therapy that we are giving to the patient. And after the intensive phase, after just 4 weeks of treatment, the general condition of the patient becomes a lot better. And the patient starts feeling what is the point in continuing this for another 5 months or 4 months. So we have to generate this knowledge and this awareness among the community members that TB treatment, once started, should be completed. And airborne infection control, today I was noticing in your posters also, which was actually wonderful by the way, but airborne infection is a frequently missed mode of transmission. So we have to ensure that the droplets which have dried up and formed lighter droplet nuclei, they do not remain in circulation in the air that we breathe. So airborne infection control is the topmost among the TB preventive measures. We have to implement measures in healthcare facilities. So the air in the TB sanatoria or the infectious diseases wards of the hospital has to be kept clean. So we have to do it first in our hospitals or healthcare facilities to reduce the transmission of TB with proper ventilation, use of personal protective equipment by healthcare workers, and isolation of infectious TB patients. So within about a month of anti-tuberculosis treatment, the patient starts becoming infectious to others. Contact tracing is another important method because once one family member becomes positive with TB, rest of the members are at a high risk of developing the disease. So we identify and test the individuals who have been in close contact with TB patients. Contact tracing helps us in early detection and prevention of the spread of TB to others. Then preventive treatment, because as you know, treatment is a secondary level of prevention. So treatment of high-risk groups like household contacts of TB patients and individuals with compromised immune systems. This can also include babies born to tuberculosis positive mothers. This helps in preventing the development of active TB disease. Vaccination, it is the most cost-effective method. Administered Bacillus calmette-guerin, that is BCG vaccine to newborns and young children to provide protection against severe forms of TB. So this you must note that most vaccines, they are given licensure if they are 80% or more than 80% effective in preventing the disease. TB vaccine has been given licensure for use even at a less than 80% efficacy just because it can prevent the complicated and severe forms of disease in children like tubercular meningitis and miliary tuberculosis. One very important aspect is community awareness and education because the effect of the drug, it starts becoming visible to the patient very early and there is always a tendency to stop the treatment. So we have to make the community aware about the importance of completing treatment and also to take preventive measures to prevent the spread of the disease to others. So we have to conduct awareness campaigns for tuberculosis, its symptoms and importance of early diagnosis and treatment. Reducing the stigma associated with TB to encourage individuals to seek care promptly. So it has been observed that particularly the females, they face some sort of, they faced in the previous decade, these studies were carried out and it was found out that females, they were hiding the disease. So if they hide the disease and don't come forward, what happens is they are transmitting and everybody in the household and in the neighborhood becomes positive. So selectively this point has been addressed and now we are detecting and treating more and more females and trying to reduce the stigma. Again, we have to educate the family members, probably the elders in the family and the husbands of the female about the risk of not having the female treated. Screening and active case finding. We do not want to miss any disease-positive cases. We do not want to miss any disease-positive cases. So what we do, we conduct regular screening and active case finding in high-risk populations and vulnerable groups, such as slum dwellers. As you know, conditions of poverty, overcrowding, poor sanitation, and even malnutrition, they abound in slums. Also in migrant workers, individuals with HIV and AIDS. So these are the high-risk populations where we need to focus our efforts on. Infection control in congregate settings, so implementing infection control measures in places with high population density to prevent the spread of TB, such as prisons, shelters, and refugee camps. Health system strengthening. So this is one of the things that we do in a pre-planning phase. That is where we have to be proactive. Once we are going to implement a program, launch a program, obviously the burden of or the caseload is going to increase. So even before launching the program, we strengthen our health systems. So we enhance the capacity. This is known as capacity building. We enhance the capacity of healthcare providers to detect, diagnose and treat TB promptly. We ensure that healthcare facilities are equipped with necessary resources and infrastructure for TB control. A few words about the very important exercise of engaging with private healthcare providers, because majority of TB patients, they report to the private practitioner first. So we have to make a public-private mix, whereas there is a reporting system and the private practitioners, they report to the CMO. Sensitization and training of the private practitioners, incentives for providers. So those who are willing to become a TB Mitra or a DOTS provider for the patient, they are being given incentives. We have standardized treatment protocols which have been developed for masses. So we have to encourage our private practitioners to adopt the standardized treatment protocols. We have to have referral and linkage systems. That is, when a private practitioner refers a case to a higher level of healthcare service or a higher healthcare provider, there is some linkage and system when the patient will come back to the referral authority with the result. TB notification. All TB cases should be notified to the district health authorities. Collaboration with professional associations and patient support and counseling. All these issues are being addressed in the NTEP or the TB Mukt Bharat Abhiyan in one way or the other. Another very important point is community involvement and awareness. So we have to carry out awareness campaigns. A lot such campaigns have been done in our field practice areas. I will be showing you the photographs in the upcoming slides. Community mobilization, that is, people who are going to be DOTS providers. DOTS, as you know, is directly observed treatment short course. So there is a TB Mitra or a DOTS provider, and that can be a government worker, that can be a person who already has had treatment for tuberculosis and recovered from it. So these people have to come forth from the community itself and not from the healthcare system. School-based program, because the basic Shiksha Mitra, who is the grassroots level worker of the education system in India, the basic Shiksha Mitra can be a very good DOTS provider or a TB Mitra. Community health workers are field workers who go for the house-to-house surveys. They can help us in active case finding, that is, people who are not yet diagnosed or people who are not coming forth with their symptoms to the healthcare system. They can be contacted by our healthcare workers who are going house to house. Public-private partnerships, we have already discussed. Reducing the stigma is very important. We have to tell the people in their language clearly that TB can be treated. And if it is not treated, it can be dangerous to others, particularly the children. And health education material, because what we hear, we forget, but if we read it, we remember it for longer time. So we have to provide the health education materials to the community members. Monitoring and evaluation of the program is of utmost importance, because World Health Organization has told us repeatedly and published also that in order to make any program successful, we have to carry out two exercises: monitoring, supportive supervision, monitoring with supportive supervision, and evaluation. So how do we evaluate the program? At the district level, quarterly review meetings are carried out to see the progress. In fact, there is a separate deputy CMO, that is a deputy chief medical officer designated just for tuberculosis. So it is the job of that deputy CMO to carry out quarterly review meetings. There are internal evaluations, because although the drugs are free of cost, we do not want to compromise on the quality of the drugs. There are external quality assessments, that is, people from outside also keep a constant watch on the quality of services being provided. This includes diagnostic as well as therapeutic services. There are annual common review missions, that is from the central government teams. They come to the states and carry out the review of many programs at the same time. Subnational TB-free certification, so the districts or the states which have made good progress in elimination of TB, they are certified by the Government of India. There is a state health index which takes into account number of patients diagnosed and number of patients treated. Data management and reporting is very important because once the data starts coming in from the private sector, we have to manage it and also report it further on. And community feedback, because ultimately the beneficiaries are the members from the masses, from the communities. So we constantly have to keep in touch and find out what the real issues are and take steps to manage those real issues. What are the challenges? India is a huge country. We have already overtaken China and we are the most populous country in the world. Unfortunately, we are a developing nation. So there is a high TB burden because of conditions of poverty, overcrowding, poor sanitation and malnutrition. So we have a high burden. And again, to compound the issue, there is stigma and discrimination. So people don't come forward for treatment and they become dangerous transmitters, particularly to children. But private sector engagement has fallen back. Private practitioners, they have to be educated, sensitized and motivated with incentives to follow the standardized treatment protocols which have been specially developed for this particular country. Workload and manpower, with the sensitization, once we do community awareness campaigns, the workload will automatically increase. So beforehand, in a proactive manner, we have to train our manpower and also we have to have infrastructure to manage the increased workload. Financial constraints, we are a developing nation. Finances, as it is, if you have studied economics, finances are always less because as humans, we always want more. So financial constraints are there and we have to manage. Drug resistance has been already highlighted. This is a huge problem which we have to manage with more cost and more adverse effects and longer treatment protocols. Coordination between the different sectors of only the healthcare sector cannot manage the disease. The patient needs more nutrition, the patient needs a better place to live, the community needs to be protected. So all the sectors or all the ministries have to converge at some point and come out with common workable solutions. Collaboration between the different sectors. Financial constraints are there, so the public sector can come in with their corporate social responsibility and so on. So looking at all the challenges and all the problems which we are facing, the Prime Minister has directly stepped in to manage the situation with the Pradhan Mantri TB Mukt Bharat Abhiyan. So Abhiyan is basically a campaign. This is a significant initiative or the campaign launched by the Government of India to accelerate the country's progress towards eliminating tuberculosis. The objectives are to provide additional patient support. So while the patient is taking tuberculosis therapy, there is a huge increase in the protein requirement. And India being, and most of the people with average income, and being vegetarians, they need support. So there is financial support for the additional protein intake to provide, but that is one aspect of support. Another aspect of support is the motivation needed to complete the 6 months long treatment, especially in view of the fact that the patient will feel a lot better after the first 4 weeks and there will be a tendency to stop the drugs in between. So we have the TB Mitra. Another thing which can compound the problem is the adverse effects. So the orange bee is there, but in addition there can be jaundice, there can be so many other problems which becomes a hindrance or an obstacle for the patient to complete the treatment. So the TB Mitra or the DOTS provider will be a constant support. And there are so many other initiatives like the digital reminders which are sent by the Nikshay portal. And Nikshay portal also has so many other features, but for the patient, there is a reminder which comes by WhatsApp. So there are many additional support points as per this campaign. Also, we need to augment community involvement to meet India's commitment to ending TB. If we want to end it, we have to place the people's health in people's hands. Because a system is sustainable only if the community becomes involved with it. If I go to some place, give the services and come back, when I come back, the services will stop. So people themselves have to start managing the services. And also we have to leverage the corporate social responsibility activities of big industrialists or big names in the private sector to support the TB control efforts. Like I mentioned, the Nikshay Mitra initiative. So the Hindi name for tuberculosis is Kshay Rog. So this initiative encourages community support for TB patients in diagnostic, nutritional and vocational areas. And Nikshay 2.0 portal extends community support to TB patients and leverages CSR. Community engagement aims to create a mass movement by raising awareness about TB, reducing the stigma and encouraging people to seek timely diagnosis and treatment. And the summary and call to action is in the future plans to enhance community engagement, strengthen the health systems and continue implementing the Pradhan Mantri TB Mukt Bharat Abhiyan. And this is what Department of Community Medicine has been doing. We have registers, we refer patients, we have the list of positive cases. This is what is happening in the OPDs at RHTC and UHTC. This is what is happening in the field practice areas. You can see an Anganwadi where awareness talks and campaigns are being held, and similarly in the other field practice areas. Thank you for your patient listening.
Thank you, Dr. Megha ma'am, for enlightening our young minds regarding the current tuberculosis program running in India. Now, moving on towards a poster competition, we are thrilled to have witnessed such amazing creativity and powerful messages from all the participants. Each of our students has contributed in a meaningful way for raising awareness about tuberculosis. Our students' hard work, passion and dedication truly shine through their artwork. So, let's see their posters. Group 1, they have made poster on Introduction to Tuberculosis. Group 2, on classification of anti-tubercular drugs. Group 3, on clinical features and diagnosis of tuberculosis. Group 4, on extrapulmonary tuberculosis. Group 5, complications of tuberculosis. Group C, drug targets of anti-tubercular treatment drugs. Group 7, on an ADR of first-line anti-tubercular drugs. Group 8, on treatment of pulmonary tuberculosis. Group 9, new drugs of tuberculosis. Group 10, revised National Tuberculosis Control Program versus National Tuberculosis Elimination Program. Group 11, on multi-drug resistant tuberculosis. Group 12, on treatment of extensively drug-resistant tuberculosis. Group 13, on treatment of tuberculosis in pregnancy and in children. Group 14, in importance of education in tuberculosis treatment. And the last group 15, on tuberculosis and stigma. Break the silence. So, now the moment we have all been waiting for the announcement of the winners. We had a panel of distinguished judges who carefully evaluated each entry based on creativity, relevance to the theme, visual appeal and overall impact. After much deliberation, we are excited to announce the winners. So, starting with the third place, the winner. Okay, so tell us, who do you think is the winner is? Which group? First, second, third, first to 15, कौन सा group है? 12? Okay, so the third prize goes to group 3. So the group 3 has the serial number from 21 to 30. Their topic was clinical features and diagnosis of tuberculosis. So I request Dr. Rashmi Singla ma'am along with Dr. Tariq Masood sir to give away the certificates to the winners. Come on, clap for your friends. Group 3, come on the stage. Chalo. Sir, please. Sir, Sir, ma'am, please come. And group 3, come on. Take your certificates and please cheer up your friends here. Come on. Okay. जी मैम.
अश्मित डुबाल, अश्मित डुबाल, अविनाश देवलिया, आयुषी राणा, भाविनी दास, भूमिका लता, जयक अग्रवाल, चिराग सिंघल, दीक्षा, दीपाक्षी, दिशा, दिशा.
Okay. So thank you so much, Tariq sir and Rashmi ma'am, for giving away the certificates. Okay, so the second winner, second prize winner. What are the guesses? 9, 4. बस और कोई नहीं. हाँ, पोस्टर्स इतने अच्छे बनाए हैं, अब तो चीयर अप करो. Okay, so the first runner-up team is Group 7 from serial number 61 to 70. And they have made poster on the adverse drug reactions of first line anti-tubercular treatment. So I request Dr. Shashi Munjal ma'am along with Shalu Baba ma'am to present away the certificates to the winners. Ma'am, please come. Okay, so the names of the students for group 7 are Preeti Shaukin, Preeti Shaukin, Rashika, Riya Pal, Riyanshi Goyal, साध्वी संग्राल, साक्षी झा, समान्यु ढिम्बी, साम्या फरीन, संचिता महाजन, and Sanjeevni Rangan. So congratulations, Rangan. So congratulations to all the winners. Congratulations. Now the much awaited award. So who will be the winner?
9.
I think 5 or 6.
9.
Sure. So now finally the time to reveal the winner of the first prize for the poster competition, and the winners are Group 4. Yes. Serial number 31 to 40, and they have made the poster on extrapulmonary tuberculosis. So our streptomycin has won the award. So I request Dr. Suman Bala ma'am along with Dr. Anjali Chaudhary ma'am to present the certificate to the winners. Please come ma'am.
भाई फर्स्ट ग्रुप के लिए भी कोई तालियां नहीं है।
So the student for the first row. Yeah. Okay. So the students of the fourth group are Gursehaj Kaur. Gursehaj come. Then Ira Singh, Isha Saini, Jay Pratap Singh, our streptomycin. जानवी गुप्ता, चलो जल्दी। Okay, so जानवी गुप्ता, ज्योत्सना, कनक जो सिरोही, कार्तिक, खुशी and Khushi Mittal. Congratulations. So your efforts have been paid off. Please give a huge round of applause for our winners. They are your friends. So congratulations to all the winners of all first and second and third prizes. So a big thank you to all our students for sharing your talents and perspectives with us. Your contributions are helping us to spread the important message and inspire the others. So at the end, I would like to invite Dr. Suman Bala ma'am, our head of department, to give the vote of thanks.
Good afternoon, respected faculty, students and staff. It's my honor and pleasure and privilege to propose vote of thanks on behalf of Department of Pharmacology on this important occasion, World Tuberculosis Day 2025. First and foremost, I would like to extend my heartfelt thanks to Honorable Chairman Shri Mahant Devendra Das Ji Maharaj for his blessing, guidance and unwavering support. We are truly grateful for his leadership. I would like to express my deepest gratitude to Principal Sir. We are highly thankful for his tireless dedication to the growth of institution. I would like to convey deep regards and hearty thanks to our Chief Medical Superintendent, Dr. Utkarsh Sharma, for his guidance and help. I convey my deep regards and hearty thanks to all our esteemed judges, Dr. Seema Acharya, Dr. Anjali Chaudhary, Dr. Sashi Munjal, Dr. Sanjeev Kumar and Dr. Megha Luthra, expertise in judging the posters. I would like to thank Department of Community Medicine, Respiratory Medicine for their contribution, and my special thanks goes to all the speakers for the event, Dr. Shalu Baba, Dr. Sravani Kanji and Dr. Megha Luthra for sharing their knowledge and experiences with us. My heartfelt and sincere thanks to our dedicated faculty, Dr. Shalu, Dr. Rashmi, Dr. Kavita, Dr. Chavi and Dr. Shruti for their meticulous planning and organization. I am also thankful to our postgraduate students, Dr. Pallavi, Dr. Shushrut, Dr. Paridhi and our tutors, Dr. Rinki and Dr. Bigdesh for their efforts which ensure seamless execution of this program. I am also grateful to our technical staff, especially Mr. Rajiv Vasi and Mr. Sanjeev Gusai and all our attendants. Your behind-the-scene effort ensured that everything ran smoothly and that all the technical experts were flawlessly executed. I am also thankful to the students, Arsh Gupta and Priyanshu for covering the whole event by providing you overview. Most importantly, I would like to thank all the students for their active engagement and thoughtful contribution. I would like to express my sincere gratitude to stage team in setting up and managing the event and to the Rangoli team, poetry recitation and role play team for their hard work and dedication. Your presence and participation have made this program truly meaningful. I would like to thank IT department for technical support, Vajpayee ji for catering services and also to caretaker and housekeeping department. Once again, thank you all making this event World Tuberculosis Day a great success, memorable for all of us, and we look forward for many fruitful discussions and collaboration in future. I thank Almighty God for all His blessings bestowed on us. Thank you.
I think everybody is a winner, no matter who gets the prize.
उसमें स्टॉप स्ट्रीमिंग कर दो, वो किस साइड से